それでは、挨拶いたします。皆さんおはようございます。
Good morning, everyone. So this is session 3-2, health surveillance. I am Shimada from Institute for Environmental Sciences. And from France, we have Dominique Laurier from IRSN. We will be the co-chairs. There's much focus on health surveillance. There are 6.
Thank you very much, Yoshia, for this introduction. So with no transition, I would like to welcome now Masaharu Tsubokura, who is going to give the second speech on non-radiological health consequences of the accident. So Masaharu, the floor is yours.
ありがとうございます。僕のスライドも音声入っていると思います。
健康管理学講座の坪倉です。この度は
So I am Tsubokura from the Fukushima Medical University School of Medicine. I will be talking about the overviews of secondary health issues after the Fukushima incident. So as for the secondary health effects, what is it? After the accident, when we think about their health effects, we need to think about radiation exposure, including internal and external exposures. These are obviously important. But in addition, we have other health effects. For example, it is quite well known about the risk of evacuation immediately after the accident, especially in hospitals and home for the elderly, the groups that are most vulnerable to disaster. And when they evacuate, there are health risks involved. And reports have been made of these health risks, and there are questions of whether or not if they should have evacuated or not. But I am not intending to raise this issue on that topic, but it has become quite clear that due to sudden change in the environment, these people who have been bedridden were severely affected, including in terms of physical and mental aspects. And these have been substantiated by data. And I would like to touch on these effects later on. And in addition, there are other, for example, psychological and mental health stress. And these have had a long-term consequences, as also lifestyle diseases, for example, diabetes, high blood pressure, cholesterol, and other various different types of lifestyle diseases. For these diseases, there has been long-term effect as a result of the accident. In addition, changes in society and also in the environment. For example, due to family separation, and the care that was done within the family, and also checking on each other's health inside the family is no longer possible. And as a result, there was an effect from that. And also changes in the local home environment, also in the local community, that also brought about health effects. And also as for radiation, as in relation to the risk perception, young people tended to evacuate more than the older people. And this has been reported. And as a result, in those communities, the population within the community became the elderly focused. And there was also depopulation and social isolation. And these also had health effects, and we need to consider them into consideration. And all kinds of hospitals and clinics, they were closed, or there were new ones opened. And as a result of that, the access to hospitals and other medical institutions, there was a significant change there. Whether the residents could have access to hospitals, and that also had an effect on the health. And also, there was a free health care services provided after the accident. And there was a change in terms of healthcare supply and demand before and after the disaster. So, for example, if the free healthcare services are provided, I tended to promote dependency, and that as a result had a health effects. In addition, we had the decontamination and restoration workers coming into the Fukushima prefecture from outside of the prefecture or outside of each of the municipalities in search of work. And these workers are not registered residents in the prefecture, and there was a question of who will take care of them in terms of healthcare. In addition, there was the use of social media, the traditional media services that spread rumors, prejudices, and accordingly, it brought about health effects on the residents. So there have been effects on individual level, family level, infrastructure level, and the society level. And we need to consider all of these health effects. And this is the first thing I would like to mention. And some of the well-known reports is the effects on the risk of death. This is in Soma, Minami Soma, on the northern side of the nuclear power plant. And I will mention that compared with before the disaster, those who evacuated, the risk of death, especially for those residents in nursing homes, increased. And in some places, 25% of residents died within the 90 days of evacuation. These have been reported. And what are the lessons can we learn from this? So this is not a question of whether or not they should have or evacuated or not, but it is about knowing, recognizing these risks in advance about evacuation, and to be able to prepare in advance with this knowledge. So most of the cause of death was pneumonia. And this could have been related to oral hygiene. Next. I would like to talk about the psychological and the mental health and on the lifestyle diseases. So we do have a wide range of data, and as already made public, there's been a Fukushima Health Management Survey conducted by Fukushima Prefecture and Fukushima Medical University, and I would like to talk about this survey. On the left-hand side, you can see the percentage of people who are mentally unwell. And the 3% line, this is the national average on the mental illness. And after the accident, immediately after the accident, there was almost 15%. And this percentage gradually decreased, and we saw some improvement. However, if you compare that with the national average, the rate percentage is still very high. If you go to the right-hand side, this involves the diabetes, people with high glucose levels. And for this, compared with before the accident, the situation is deteriorating over the long term. So something needs to be done for these people as well. And in addition, there have been health effects from changing the family environment. For example, the breast cancer patients were diagnosed only at a later advanced stage, especially in Minami Soma. So if they had been living with other family members, the other family members would notice their symptoms and recommend that the patient take a hospital visit. But since they're not living with their other family members, the symptoms are not recognized, and therefore the cancer can only be detected at a later advanced stage. In addition, for example, in Futaba region and Soma region, because they were designated as evacuation zone, the ambulances could not arrive on time, or it took more time for the ambulances to arrive. And in those circumstances, if there were heavy snow that prevented access, then that would have a significant impediment on the residents' access to healthcare services. And also there is an issue of long-term care, and because the families are separated, what had in previously they were able to look after the elderly within the family, but because of the accident, the expenditure on healthcare per capita has increased. If you look at the left-hand side, this is the nursing care cost per capita. And as a result of the accident, this has increased about 30%. And on the right-hand side, this shows the cost of, for example, inpatients, outpatients. For all of these categories after the accident, the cost arose. As for the possible causes for this increase in healthcare cost, as a result of young people leaving the region, they were no longer able to look after the elderly within their families. And also the actual physical conditions of the elderly deteriorated due to the accident. And as a result of free medical services, and this could have had impact on their health as well. In addition, many workers came in from the prefecture and municipalities from the outside. And these workers, from the outset, even before they came into Fukushima, generally their levels of care were low and insufficient. And these there were many issues arising from that. And in addition, as mentioned in the media reports, there were a lot of bullying, fake news, spreading of prejudice and discrimination on social media, and so on. And all of these had a mental and psychological damage on the residents, and that then further caused illnesses. And for those various health effects, each of the municipalities are taking various measures. And one of them is as shown here in this, some of the measures taken by Soma City. This is a community housing for the elderly called Idobata Nagaya. This is where elderly people live together and they support each other so that they can prevent the need for any nursing care. And on the right-hand side, this is a Honebuto Park. And here, elderly people can exercise to maintain health and improve their physical strength. And these kind of parks have been built. And this is not only limited to the cases of pre-accident, radiation accident cases, but generally speaking, this can prevent loss of physical strength of the elderly. So I do have some conclusions. So I did explain some of that there is a wide range of health risks. And out of these health risks, in terms of numbers, there was a health effects from early stage evacuation. As for the medium to long term, there was a significant change in the lifestyles, including the aging population, and these also had a effect on health effects, especially in terms of social. And these causes was brought about by the nuclear power accident. And it is still quite a challenge to address each of these challenges, but the municipalities are taking steps to address one at a time. So there are still various problems are remaining, and we now have the effect of COVID-19. And maybe we can find some parallels from our response to COVID-19. That concludes my presentation. Thank you for listening.
はい、坪倉先生、ありがとうございました。
Dr. Tsubokura, thank you very much.
第3番目の講演に移りたいと思います。第3番目は、福島県立医科大学の
The third speaker is Dr. Koichi Tanigawa on the third health monitoring. Excuse me, health issues today in affected near the Fukushima Daiichi power plant. This is pre-recorded session. Dr. Tanigawa, please.
I'm Koichi Tanigawa, Director of Futaba Medical Center. Since the Fukushima Daiichi nuclear power plant accident occurred, vigorous efforts have been made for environmental decontamination. The area of difficult return zone has reduced significantly, and people started to return to their homeland. As the population increased, medical needs ensued. I'm going to present what happened in the Futaba region, which was the most affected area by the Fukushima Daiichi nuclear power plant accident from America's point of view. I have no conflict of interest regarding this presentation. Soon after the accident, evacuation was ordered to 12 municipalities, including 8 towns and villages in Futaba County. A total of 98,000 people were evacuated. In 2014, the national government started lifting evacuation order from Kawauchi village and gradually expanded to other municipalities. In 2019, part of the Okuma town, where the Fukushima Daiichi nuclear power plant is located, was lifted evacuation orders. Currently, 22,000 people live in the area lifted evacuation order. The area of difficult return zone was reduced to 1/3 of the 2011, and now the area is 2.7% of Fukushima Prefecture. There remain difficult return zone areas in municipalities highlighted yellow. In March 2020, the national government designated specified reconstruction and regeneration-based area inside the difficult return zone in Futaba, Okuma, and Tomioka town for restricted residents in the future. As the population increases, more medical needs arose. For example, the number of EMS calls has been increasing by 10% every year, as shown in the upper graph. The major reason for EMS call was acute illnesses. However, when you look at more closely, the proportion of injuries caused by traffic accident and at work is much higher than the national data. Also, inter-hospital transfer is more frequent than the national average. A marked increase in traffic as well as decontamination and reconstruction project led to an increase of motor vehicle and occupational accidents. This explains in part the background of the higher proportion of inter-hospital transfer reflects shortage of medical resources in this area. Until the Futaba Medical Center was established, there were no emergency hospitals in this region. This slide shows the current situation about medical services. Before the accident, there used to be 100 medical facilities in the Futaba region. After the accident, all within 20 km from nuclear power plant were forced to close. Only 4 medical facilities around the evacuation zone continued or reopened medical practice soon. As the evacuation order was lifted and people started to return, medical needs grew. Outpatient clinics reopened. However, it was not easy to do medical practice in the areas because of shortage of medical staff, financial burden, and uncertainty about the future. To respond to increasing emergency medical needs in the Futaba region, Fukushima Prefecture government established an emergency hospital in Tomioka town in 2018. Futaba Medical Center Hospital is located 8 km southwest from the Fukushima Daiichi nuclear power plant. The major role of the hospital was to provide emergency medical care, disaster responses, including to radiological emergency. Although a small hospital with 30 beds, it operates round the clock, 7 days a week, 365 days a year to meet local emergency needs. Also, it was expected to provide home care and contribute to support of comprehensive community care because more elderly people with physical disability returned. Efforts for health promotion were required for residents with multiple medical problems and workers with health risks such as diabetes and hypertension. In order to achieve these goals, good collaboration is needed with hospitals, medical facilities, healthcare providers, and local municipalities in and out the region. In particular, tight cooperation with Fukushima Medical University is prerequisite to ensure the quality of care and continuity of the project. Over the last 2 years, we responded to 60% of the emergency medical needs in Futaba region. The number of ER visits increased 50% in 2019 compared to the previous year. Regarding the residence of the patient, Naraha, Tomioka, and Hirono account for more than half, reflecting population of those municipalities and proximities to the hospital. On the other hand, those from outside the Futaba or Fukushima Prefecture account for 35% of the ER visit. These patients suffered injuries mostly due to traffic accident or occupational injury. In the upper graph, there are two peaks of age distribution of the patient, that is 50 to 59 and 80 years old. The lower graph shows the diagnosis of the patient based on ICD-10 classification. As you see, injury is the most frequent reason for ER visit, followed by respiratory problems. The younger age group visited ER suffering from injury, and so did the older group complaining of respiratory problem. As for admitted patients, those aged over 80 years old account for 60% of admission. Similar to the diagnosis and ER visit, the top two reasons for admission were injury and respiratory problem. However, most of the injury required admission were mainly fractures related to osteoporosis. A majority of respiratory problem is due to pneumonia. Osteoporosis and pneumonia are very common medical problems among elderly people. On the other hand, patients with major trauma, acute myocardial infarction, and stroke required advanced medical intervention, and therefore they were transferred to designated medical facilities such as Level 3 Trauma Center or Stroke Center in Iwaki or Minamisoma. This slide summarizes medical issues in Futaba region. Marked increase in traffic as well as decontamination and reconstruction project led to an increase of motor vehicle and occupational accident. Acceleration of population aging resulted in an increase of elderly residents with multiple medical problems requiring careful medical attention. Uncontrolled, untreated medical problems among middle to old age workers made them susceptible to deterioration of health conditions, requiring emergency and more intensive treatment. And finally, insufficient social support for elderly people living alone resulted in delayed access to medical care. Health issues are not limited to medical problems. More than 40% of the residents are older than 65 years old, and most of them have chronic illnesses. Early intervention, as well as prevention of health deterioration, are the key. We need to engage more aggressively in home visits for elderly patients. Also, we emphasize health promotion in collaboration with local municipalities, such as holding open class for the residents and comprehensive community care events. Key concept is proactive approach. In order to address family and community issues, we need to get involved in comprehensive community care, which is organized by municipal government and social welfare liaison. Last but not least, development of human resources is crucial to implement above-mentioned activities. We need close collaboration with academic institutions, organizations, and municipalities. When we think about return to homeland, we need to facing realities. Evacuation orders have been lifted and people are returning. However, 80% of the residents have not returned yet. What do they think? In Tomioka and Namie town, where the evacuation order has been lifted for 3 years, 16 to 18% of the residents were those who have already returned or wish to return. About half of the residents have decided not to return. In Okuma and Futaba towns, where the evacuation order was lifted the latest, only about 10% want to return, and 60% have decided not to return. Most of them have established their lives in the evacuation site. The longer the evacuation order is lifted, the fewer people want to return. Orita and Nagasaki University team investigated the psychological status of former residents of Tomioka town and their intent to return 8 years after the accident. They found that concerns about consuming locally sourced food and tap water in Tomioka were significantly more prevalent among those who were undecided about returning and who had decided not to return, compared with residents who had returned to their homeland. Frequency of residents who felt that cancer would occur due to radiation exposure and that genetic effect would arise in the next generation due to living in Tomioka were also significantly higher among those who decided not to return and were undecided about returning. Studies have indicated that perception of risk of radiation exposure was closely associated with intent to return home. Given their well-being and already established lives in the evacuation site, it can be said that returning is one of the options, not all. We are facing two challenges. One is universality. Before the nuclear accident, Futaba had been suffering from an aging population, depopulation, and shortage of medical resources. The nuclear power plant accident underscored those issues. However, in Japan, those issues are not unique to Futaba region. The Fukushima accident clearly highlighted medical and public health issues that exist elsewhere in Japan. The other is reality. We are trying to rebuild a community where all residents were once evacuated after a major nuclear accident. Challenging is to the people is to rebuild a sustainable society in the post-nuclear power plant accident site that is unprecedented. Our experiences would provide a basis for future planning following a nuclear accident. Thank you very much for your attention.
はい、谷川先生、どうもありがとうございまし
Dr.
た。
Taniga, thank you very much.
Thank you, Professor Tanigawa, for this very interesting presentation. I know Kayo Tokawa from the IARC, and our presentation will deal with the effect of thyroid screening. This is a pre-recorded presentation. So next speaker is Kayo. Kayo, the floor is yours.
Hello, thanks for having me. My name is Kayo Togawa. I am an epidemiologist working at the International Agency for Research on Cancer based in Lyon, France. I'm going to present the IARC technical publication number 46, which was developed by the expert group on thyroid health monitoring after nuclear accidents, which was convened by IARC in 2017. Today, I'm presenting on behalf of the group. First, I just want to introduce our fantastic expert group who worked together to develop this report. Not all members are shown in the photo here, but the group consisted of 14 experts, 3 specialists, and 4 advisors from various disciplines, including cancer screening specialist, radiation epidemiologist, pediatrician, surgeon, dosimetrist, etc. This group was convened by IARC in order to develop recommendations on thyroid health monitoring as part of preparedness and response to any future nuclear power plant accident. Okay, so in my presentation, I'm going to speak about what we learned from past nuclear power plant accidents with a focus on thyroid cancer, and then potential benefits and harms of thyroid cancer screening outside the context of nuclear power plant accident. And then I'm going to present the expert group's recommendations with some additional considerations. The accident at the Chernobyl nuclear power plant occurred in April 1986. It caused a large release of radioactive materials into the environment, and it led to widespread radioactive contamination and exposure of millions of people to radioiodines and other radionuclides. Following the accident, extensive efforts were made to investigate potential consequences of the accident. For instance, a large-scale thyroid dose monitoring was implemented, and it identified that consumption of fresh milk contributed large doses to the thyroid. And also a register of thyroid cancer was developed. This register allowed for evaluation of thyroid cancer incidence trends in the affected populations. Here, the figures are showing the incidence trends in childhood and adolescent populations in Belarus. We can see a sharp increase in the incidence of thyroid cancer from about 4 to 5 years after the accident. This phenomenon was also observed in Ukraine and the Russian Federation. After the observation of such sharp increase in thyroid cancer, there were international and national efforts to construct screening cohorts in the affected populations. And these cohorts generated valuable scientific evidence about dose-effect relationship between radiation exposure during childhood and the risk of developing thyroid cancer. I won't go over the results from each study, but in summary, they consistently showed a significant elevated risk of thyroid cancer with an increasing level of exposure to radiation during childhood. Another important point we learned is that the survival of thyroid cancer cases that occurred after the accident was very high, even for patients with an advanced disease. For children and adolescents exposed to Chernobyl fallout, thyroid cancer-specific long-term survival was 98 to 99%, which is similar to the survival of papillary thyroid cancer in pediatrics in general. Now moving on to the Fukushima Daiichi accident, which occurred in March 2011 after the Great East Japan earthquake and a major tsunami, which affected a wide area including the Fukushima Daiichi nuclear power plant. This resulted in an extensive release of radioactive materials into the environment, but because of the protective actions such as sheltering, evacuation, and control of food, milk, and water, The radiation dosage to the local population was considerably lower for the Fukushima accident than for the Chernobyl accident. The estimated thyroid dose was up to tens of milligray in infants in the case of Fukushima Daiichi accident, whereas that was up to 50 gray in children in the case of Chernobyl accident. Despite the low doses, there was a high level of anxiety about radiation exposure and thyroid cancer risk among the public. And to address residents' questions and anxiety, various actions were taken, such as leaflets, workshops, and counseling. In response to the public's concern, the local prefectural government, together with Fukushima Medical University, initiated the thyroid ultrasound examination program in October 2011. This program targeted all inhabitants of Fukushima Prefecture aged 0 to 18 years at the time of the accident. The baseline survey, which was conducted during the first 3 years after the accident, examined more than 300,000 subjects. Of those, nearly 2,300 were screened positive and underwent confirmatory examination. Of those who were screened positive, 116 cases were detected, and these cases are deemed to be unrelated to radiation. And this baseline survey revealed that subclinical thyroid cancer, as well as benign nodule or cyst, occur not only in adults but also in children and adolescents, with the prevalence increasing with age. Beyond what I've just spoke about, these accidents and all the efforts that were made following the accidents have significantly advanced our knowledge and are still teaching us a lot of important lessons. Now I'm going to switch gears and talk about the principles of cancer screening and potential benefits and harms of thyroid screening, which the expert group reviewed to guide their decision for their recommendations. Let us first revisit the definition of cancer screening. Cancer screening is an application of screening test in a presumably asymptomatic population with the intention to reduce mortality and morbidity through early diagnosis and treatment. For a cancer screening program to be successful, it should be a common cancer with high associated morbidity and mortality. There should be effective treatment, and test procedures should be acceptable, safe, and inexpensive. For thyroid cancer, it does not quite meet the first criterion because it's a rare disease, and thyroid papillary carcinoma, which is the predominant type, has generally a very favorable prognosis. Also, we have to remember that any cancer screening program comes with harms, so the balance between benefits and harms should be carefully evaluated when making a decision. The balance between benefits and harms of cancer screening depends on the type of cancer and other factors. Now, what are the potential benefits and harms of thyroid screening? Potential benefits include less aggressive treatment and subsequent lower risk of treatment-related complications. However, at this stage, it cannot be predicted with certainty which cancer will progress to an advanced state. So there is the risk of overdiagnosis. Overdiagnosis is detection of cancers that would have remained asymptomatic during a person's lifespan. Another potential harm is false positive, which may cause anxiety. On the other hand, those who receive negative results may be reassured. Another potential harm is loss of credibility, in another word, public distrust, which can happen when a program is not effective or it diverts essential healthcare resources. Based on those concerning potential harms of thyroid screening with the limited evidence on clinical benefits, the expert group recommended against population thyroid screening after nuclear accidents. The recommendation might end there if there is no nuclear accident. But in case of a nuclear accident, the expert group also recommended that consideration be given to offering a long-term thyroid monitoring program for higher risk individuals. Higher risk individuals are defined as individuals exposed in utero or during childhood or adolescence with a thyroid dose of 100 to 500 milligray or more. I just want to make a note here that these recommendations were made with the acknowledgement that what's best for a given population depends on the population, available resources, and also social values. Therefore, the expert group emphasized that final decisions should be made based on open dialogue among policymakers, experts, stakeholders, and the community. Now, what's thyroid monitoring program? Thyroid monitoring program includes education to improve health literacy, registration of detected cases, and individual clinical examinations and treatment. Through the program, the participants would be informed about potential benefits and harms of thyroid examination and make a choice through a shared decision-making process. The decision is whether one would prefer to have an earlier diagnosis, to potentially reduce the aggressiveness of the treatment, or not to search for the disease with the possibility of more extensive treatment later in life, but also the potential to never be diagnosed and hence to undergo no treatment at all. Now, some of you may be wondering, what's the difference between monitoring and screening? Thyroid health monitoring and thyroid screening both aim for early detection of the disease, but these programs are otherwise distinctively different. For example, the objective of screening program is to reduce mortality and, if applicable, morbidity, with public health benefits outweighing the harms, whereas the objective of monitoring program is to empower higher risk individuals to make an informed decision with perceived individual benefits outweighing the harms. Another example is the recruitment goal of the screening program is to achieve high participation to ensure the effectiveness of the screening program, whereas the goal of monitoring program is shared decision making between the family and clinicians. For the sake of time, I won't go into details, but I welcome you to visit our website and download the report for further details. In addition to thyroid health monitoring, the expert group also highlighted the importance of following measures as part of preparedness and response. For surveillance, there should be a monitoring infrastructure such as population-based cancer registration to assess the likely health consequences of an accident. For risk assessment, there should be dosimetric monitoring for a large number of individuals, ideally with direct measurement. For protection, oral administration of potassium iodide is important. Lastly, to alleviate the public's concerns about radiation and thyroid cancer, risk communication is important, and it should be done proactively, which can facilitate the communication in the case of an accident. So this is the end of my presentation. I would like to acknowledge the team members listed here, including Dr. Laurier, that made the TMNUC project extremely fruitful and enjoyable. And I would like to thank you all for your attention. If you have any questions or comments, please feel free to email me at togawak@iarc.fr. Thank you.
OK、ありがとうございました、戸川先生。それでは、
Thank
次
you
の、
so much, Ms. Togawa. We'd like to move on to next one.
Thank you. Elizabeth, the floor is yours.
Thank you for the opportunity to speak in this important session. I'd like to talk to you about the Shamisen, a project funded by the European Commission. In Shamisen, we reviewed lessons learned from previous nuclear accidents and developed recommendations for medical surveillance of populations affected by radiation accidents, trying to respond to their needs and avoiding unnecessary anxiety. The Shamisen consortium included 18 institutions from Europe and from Japan, as well as key actors in the follow-up of the Chernobyl accident and other experts in emergency response, psychology, philosophy, psychiatry, and ethics. And here are some of the members of Shamisen at a meeting in Paris. You'll note that a number of them are present here today. Okay, what have we learned in Shamisen? First of all, the goal of health surveillance programs set up after previous accidents was not always clear, and in many instances, particularly after Chernobyl, they were more aimed at epidemiology than actual health surveillance, and this is not always compatible. A health surveillance program should be set up either to improve the general health of an affected population and or to prevent or reduce the impact of an accident or of the exposure resulting from that accident. In the same line, a program needs to be well justified. If the objective is to reduce radiation effects, then the population under surveillance should be a population with exposure levels sufficiently high to cause adverse health effects that can be reduced. And finally, while a health surveillance program is meant to be beneficial and also to be reassuring to populations, we have to keep in mind that it can increase anxiety. People who are under observation, under follow-up, might wonder why they are and feel stigma or discrimination and stress because of the surveillance program. And they may also feel distrust when a surveillance program is stopped because of lack of funding. And so it's very important, if we're going to set up a surveillance program, to be sure to ensure that it's sustainable. Alternatively, people who are not in the surveillance program may feel discriminated against and also distrust the authorities. And importantly, a surveillance program might lead to overtreatment, and this can worsen the quality of life and morbidity in population. So the really important issue is whether or not to set up a surveillance program and who the population under surveillance should be. Another very important lesson is that health surveillance raises a number of ethical issues and challenges. One is respect for autonomy, so the free will and decision-making capacities of individuals in affected population. One is justice, distributing the benefits, the risk, and the cost fairly in the population. Another one, obviously, is avoiding the causation of harm, so non-maleficence, and of course, providing benefits, beneficence. And this leads to the WHO principles for systematic screening. WHO recommends systematic screening when it can lead to detection of early abnormalities, for example, pre-malignant changes or early malignancies, when there are preventive strategies or treatment which can improve the health outcome. And we have to remember that early detection doesn't always improve health. For example, PSA screening for prostate cancer can result in a lot of false positive and overtreatment and detrimental effects. It's very important that the potential benefits of screening outweigh any potential harms. This is an ethical principle, and there must be a strong evidence that the screening program is effective in reducing mortality and or morbidity and is cost effective. Based on these lessons, we can outline a roadmap for health surveillance. The first thing is to define the objectives, as I just mentioned, but also the outcomes to be followed. And depending on the objectives, this can be cancer and other radiation-related health effects, or it could be non-radiation-related health effects, including mental health. And psychosocial follow-up should be an integral component of health surveillance. Another aspect is identifying other factors which may contribute to the development of the adverse health effects and which may be subject to interventions. Define the scope of a surveillance program based on an assessment of the exposure levels or based on an assessment of the size of the affected populations and their vulnerability and the severity of the health conditions we want to look at. And of course, adapt to the needs and concerns of the affected population through continuous communication. Key elements for a successful health surveillance program include accountability, so clarify all responsibilities. Transparency on the expectation, on the purpose, having a clear communication strategy and clear information to participants. And stakeholder participation, of course, is critical for success. This includes engaging health professionals and communities and parents in the case of children in the design and in the review of health surveillance programs. Also need to take into account the positive and the negative consequences of health surveillance, provide access to and advice on the use of personal dosimetry and monitoring tools to empower our participants and respect their autonomy and free choice. The Shamisen Consortium prepared 27 recommendations, 7 general recommendations, and 20 which are divided between the preparedness, early and intermediate, and long-term post-accidental phase. And you see that they are color-coded, with green being those that are specific to health surveillance, although some of the others are also related to health surveillance. In the general recommendations, that there are 2 that focus health surveillance specifically. If we look at each recommendation is set out this way, with the text of the recommendation, the motivation, the how it can be implemented, and who it is addressed to. The first recommendation is to encourage a health surveillance strategy that targets the overall well-being of the population and doesn't only address radiation effects. Why? Well, according to WHO, health is a state of complete physical, mental, and social well-being, not only the absence of disease. And it's quite clear that the negative consequences and potential benefits of health surveillance go beyond the direct impacts of radiation exposure. They include psychosocial and health impacts caused by stress and anxiety, by emergency evacuation, as well as the socioeconomic, cultural, and other societal impacts. And these can lead to a range of lifestyle-related diseases among the exposed populations. How can this be done? Well, using a multidisciplinary approach, including psychologists, mental health specialists, sociologists, health economists, radiation protection experts, epidemiologists, general physicians, and other stakeholders able to take into account the concerns and expectations of local populations. And in this respect, the participation of local health practitioners and actors should be especially encouraged. This recommendation is aimed at health authorities, medical professionals, academic and other research centers, and local citizens. The second general recommendation is to ensure that health surveillance respects the autonomy and dignity of affected populations and is sensitive to any inequity in the distribution of risks and impacts. Dignity and autonomy are most commonly linked to questions about self-determination and choice, while fairness and justice relates to the way in which the risk, the cost, and the benefits are distributed in the population. Actions that can help people gain control over their lives and situation can strengthen dignity and respect autonomy. This includes provision of monitoring equipment and of information that can help populations make their own decisions and actions, and engaging populations in decision-making. Respect for dignity includes the nature of the personal data collected, how it is stored, how it is used, and how results are disseminated. For health surveillance, this means paying attention to the expectations and to the expected benefits and cost of the surveillance for the participants. In terms of being sensitive to the distribution of risk benefits, this includes, for example, concern and responsibility for children, as well as acknowledging and attempting to redress any inequities. This recommendation, again, is addressed to health authorities and medical professionals, as well as to research centers and local citizens. Some of the recommendations for communication and training are also relevant for health surveillance. For example, in the preparedness phase, fostering the participation of stakeholders and communities in emergency and health surveillance planning, and in the long-term post-accidental phase, building networks of experts, local facilitators, and populations in order to provide the populations with the tools and the information for them to make their own decisions and to do their own protection. Consider the preferences of people living in affected areas and foster the long-term participation of affected populations and communities. In terms of specific health surveillance recommendations, in the early and intermediate phase, we have created a common roster of affected populations. This is essential for the planning and the conduct of efficient health surveillance. And in the long-term phase, to expand the support of populations to take into account economic and social upheavals, which have health consequences, and to be very careful in launching systematic health screening. Basically, it should be based on appropriate justification design, and specifically, we do not recommend systematic thyroid screening, but only to make it available with appropriate counseling to those who request it. We think it's very important for the recommendations to be disseminated and implemented, and for this we have prepared a booklet in English and in Japanese with the full recommendations. Infographics in various languages aimed at less specialized stakeholders, including the general public, scientific publications, in particular a special issue of Environment International with 9 publications from shamisen. And of course, the members of the consortium and our experts are all members of the radiation protection and accident preparedness communities. And so we take every opportunity to present findings and recommendations in scientific and other workshops, such as the meeting today. And finally, we are trying to disseminate further because recommendations apply not only to radiation accidents, but we also think that they apply to other environmental and public health crises. And recently we have issued a policy briefing where several of us actually adapted and translated the shamisen recommendations to the COVID situation. Thank you very much, and if there's a minute, I'll be happy to answer questions.
はい、カーディス先生、どうもありがとうございまし
Dr.
た。
Cardis, thank you very much for your input. Next, shall we go back to Dr. Maeda? Dr. Maeda, are you ready?
これから最後のセッションになりますけど、トークになりますけども、前田先生、よろしくお願いいたします。
先ほどどうも、すみませんでした。
Sorry about the confusion.
Can you see my slide? Okay?
OK です。
So my talk is about mental health issues and psychological care for affected people after nuclear crisis. And my talk is based on my experience and the evidence from our mental health surveys. First of all, I would like to show a differences between natural and nuclear disasters. There are many differences between natural and nuclear disasters compared to natural disasters. In major nuclear disasters, such as Fukushima disaster, impact of trauma is more chronic and complicated. In Fukushima disaster, affected area is invisible and unclear. For example, we cannot make definite clear borderline between affected and non-affected area. It should be very difficult for evacuees to accept physical losses compared to natural disasters. In addition, widespread public stigma towards radiation exposure and monetary compensation were often induced. Such social reactions are almost never seen in natural disasters. The number of evacuees reached over 160,000 at maximum. As relief process, including decontamination, progressed, habitable areas have been increasing again. However, nearly 40,000 people are still evacuated, about 30,000 of whom stay out of Fukushima. This slide shows changes of the number of evacuees inside and outside of Fukushima. As you can see, while the number of evacuees inside Fukushima decreased yearly, that of those outside Fukushima decreased only a little. Even now, nearly 30,000 stayed very far from their original towns. In the initial but not brief phase of the Fukushima disaster, while most people and experts focused on only the direct effects of radiation exposure, such as the thyroid cancer, other health risks were ignored or seldom considered. However, as time passed, a variety of non-radiological health problems gradually emerged. As you can see, in contrast to two prefectures mainly affected by tsunami, only Fukushima Prefecture has a great proportion of indirect deaths. We call disaster-related deaths, resulted from long-term evacuation. Unfortunately, until now, over 2,000 people died from various chronic illness caused by long-term evacuation, as Dr. Tsubokura mentioned. Also, this slide shows the number of disaster-related suicides in 3 prefectures. Similar to the previous slide, the total number of disaster-related suicides in Fukushima reached 140, which is much higher than those in other affected prefectures. As you can see, different to other prefectures, the number of the suicide reached its peak 3 years after the accident. This delayed effect indicates stressful life of long-term evacuation. And severe nuclear accident can produce different health effects, including mental health problems among affected people. So we have been performing major surveys named Mental Health and Lifestyle Survey since 2012, 1 year after the accident. This survey has several purposes. First is to clarify current mental health problems and lifestyle-related issues. And we've been trying to provide brief intervention using the telephone for the people at risk of PTSD, depression, or other physical problems. This shows a target population of our surveys. We've been making about 200,000 residents living in the disaster area, many of whom are evacuees. And we divided the target population into 5 groups according to age, as shown in this slide. According to our survey, prevalence rate of probable depression among the target population have been gradually decreased, but still considerably higher than that of general population in Japan. Furthermore, the prevalence rate in those who stayed outside of Fukushima is higher than that in those inside. Relocation to a remote area might distress many people due to unfamiliar situations. Meanwhile, with regard to prevalence rates of children having some behavioral and emotional problems related by their parents, prevalence rates in all age groups also decreased to almost the same level as that in control. However, similar to the adult prevalence rates of the school children staying outside Fukushima are higher still higher than those staying inside. Our survey also clarified
小川
radiation
先生、集中のところ申し訳ありませんけども、スライドプレゼンテーションモードに変えていただけますでしょうか。
Dr. Maeda, can you change your slide into presentation mode?
すみません、これですね。
はい、ありがとうございます。
Thank you very much.
Clarified radiation risk perception among the target population. This slide shows worries about the genetic effects of the Fukushima accident among them. As shown in this slide, the proportion of people having worries about that decreasing yearly during the first 4 years. But nearly 40% still have worries about that. We are very concerned with the results because they might result in self-stigma towards reproduction or rearing children among affected people. In addition, we found that there was a strong association between mental health problems such as depression and radiation risk perception towards genetic effects. Despite unknown causality, this result suggests that we should deal with worries about radiation effects and mental health problems at the same time. And next, I would like to talk about that approach to those evacuated in remote area. Outreach visit service is often very difficult. On the other hand, telecommunication, using telephone or internet is very useful. Sharing correct information about current situation is needed. Multidisciplinary approach is required. Actually, we Radiation Medical Science Center in Fukushima Medical University has a support team consisting of 70 health professionals, such as clinical psychologists, social workers, and public health nurses. They have been performing telephonic intervention for evacuees identified at risk of some mental health problems, such as depression, based on the results of our survey. The total number of those who received this telephonic intervention reached over 30,000. The last thing that I would like to emphasize is that engaging in long-term relief work or providing long-term health care for evacuees might bring substantial psychological burden to different workers. For example, our interview survey for public employees working in disaster area reveals that surprisingly nearly 80% were diagnosed as depression, as well as residents and evacuees. Continuous long-term support for various workers working in the disaster area should be required. Thank you for attention.
Thank you very much, Dr. Maeda, for your very interesting presentation. We are a little bit over the time now. I don't know if we have time to welcome 1 or 2 questions of the panelists that are still there. Maybe we can take 1 or 2 questions. Also, I would like to inform the participants that there are 7 additional presentations that are available on the website of the Congress from Russia, from Japan, and also from a European project, Shamisen Sings. So don't hesitate to go and have a look at this very interesting presentation that were not presented here, but that are available on the website. I don't know, I'm looking at the organizers. Do we have time for 1 or 2 questions? There have been very interesting questions that are available on the question and answers, so a little bit more than 20 questions. So I think we have no time to go in detail in the different questions, but they will be sent to each of the panelists, and the answers to the questions will be available soon on the conference website. I don't know if we have time to check to select one question. Maybe we should end up the session right now. So thanks to all of the panelists for this very interesting session. And Dr. Shimada, I give you the floor for the very last point.
はい、パネリストの皆様どうもありがとうございました。また
Thank you very much for the panelists, and thank you very much for the audience. We did receive a many number of questions. Thank you very much. And so there are various effects from the radiation from the nuclear power accident. We focused on that. We also looked at the psychological and mental effects, as well as social and effect as well. We do have various issues. We need to have the involvement of various stakeholders to clarify the objectives and draw up the roadmap and strategies going forward. So we would like to move on to creating a concrete strategies for the future. So that's my final comment. Thank you very much.
Thanks again to all the panelists for this very interesting session.